So thank you everyone for joining our Alone at Home series, which we hold every other month. Today we have a presentation from Dr. Philip Kuball. Dr. Philip Kuball is the Cognitive Neurology Fellow for the 2025-2026 academic year at our ADRC, and he has completed his adult neurology residency at NYU Langone Health, where he served as our chief resident. And during his residency, Dr. Kubal engaged in a range of research projects, including studies on the relationships between traumatic brain injury, neuropsychiatric symptoms, and Alzheimer's disease, as well as early clinical outcomes of patients treated with Lecanemab at NYU. And he's originally from Minnesota and earned his medical degree from the University of Minnesota. And outside of medicine, he enjoys exploring new restaurants in the city, watching and playing sports, and going to movies and spending time with family and friends. And with that introduction, I will turn it over to Dr. Kubal, who will give us an amazing presentation today.
Okay. Thank you so much, Shabana, for that introduction. So like she said, I'm Phil Kuball, the Cognitive Neurology Fellow here this year at NYU. I'm going to be talking about Alzheimer's disease, and specifically Alzheimer's disease treatments in the past, the present, and the future. So I'm so excited to be here. Thank you all for joining. I have no disclosures for today's talk. So just a brief outline of what I'll be covering. I know I mentioned treatments, but we're going to start kind of even earlier, just a brief history of Alzheimer's disease, or AD, talking about its origins, what causes it. Then we'll move on to kind of how we diagnose it in the past and in the present now. And then we'll move into treatments, how it was treated in the past, how it's being treated now, and then what we're seeing here at NYU in the clinic with the current treatments. So give some statistics on that. And then I'll talk about future treatments for AD, and finally we'll conclude with some takeaway points. So let's start with this. What is Alzheimer's disease? I'm sure many of you are familiar with the disease, but we can't talk about it without talking about Dr. Alzheimer, who is pictured there on the far left. So he was a German psychiatrist and neurologist, and really before 1900, 1901, memory loss was considered normal. It was a totally normal part of aging. However, in 1901, Dr. Alzheimer treated a patient named Augusta Dieter, who is pictured there to his right, who at the age of 51 alarmingly showed signs of very severe memory loss. Fast forward a few years when she unfortunately passed away, under the microscope, her brain showed these odd plaques and tangles. And eventually, this led us to determine that dementia, or memory loss causing impairment of function, was not a normal part of aging, but instead a specific disease process. And those plaques and those tangles are shown there on the right. I'll get into them next here a little bit more. So those plaques and tangles, as we probably know, have been come to be called amyloid plaques and tau tangles. So the picture on the left, the blue kind of weird looking things are the amyloid plaques, whereas the orange things more within the cell are the tau tangles. And on the right, I just wanted to show a picture of a healthy looking brain, kind of on the left side of the schematic, where you can see the cortex is full, the ventricles are of normal size. However, in severe Alzheimer's disease, what we see is a shrinkage of the cortex, enlargement of those ventricles, which house the fluid in the brain. And that's, thought to be due to these amyloid plaques and tau tangles. But kind of raises the question, how do these plaques and tangles cause the disease? Well, we are kind of operating under this hypothesis of this amyloid to tau to neurodegeneration system, or ATN system. It starts with amyloid, a specific abnormal type of amyloid called amyloid beta, or A beta. What happens is we think it clumps together to form these plaques. As we know, it's one of the disease's key markers. But after those plaques are kind of formed, it leads to the development of these tau proteins, and they start to tangle up. They block the cell's transport systems. It makes it more difficult for brain cells to communicate with each other. And then around this time, we think the immune system gets involved. And I'll talk more about the immune system a little bit later, but these brain cells called microglia and astrocytes are activated, and it leads to inflammation, which causes more problems, specifically synaptic dysfunction. So brain cells talk to each other through synapses. So if those synapses are not functioning, brain cells can't speak to each other, which leads to troubles with memory and thinking and all domains of cognition. But eventually, this pathway, we believe, kind of leads to neurodegeneration or the death of brain cells. And again, we'll kind of cover this a little bit more. This next schematic I really like because it kind of shows us that on the far left, you can see that A beta or that amyloid. It really starts to build up years and years before patients develop cognitive impairment or develop memory loss. We see it starting very early, but then over time that leads to this tau kind of mediated injury of neurons and tau driving dysfunction. But still, it's kind of even before we can detect clinically meaningful memory loss. But then comes the brain structure changes or the neurodegeneration, and that's when we start to see the symptoms kind of rear their ugly head in the clinic: memory loss, other domains of cognitive impairment, and then that eventually will lead us to a decline in clinical function, which is what we call dementia. And there are stages to dementia, as I'm sure many of you know. It starts, as many things do, with normal. There are no symptoms, no decline in function. The next stage is what we call the preclinical stage. And this could be somebody that feels like they have symptoms, feels like they have a decline in their memory or they're thinking of some sort, but we can't really detect it objectively on testing, neuropsychological testing or cognitive testing. Or the preclinical stage could refer to people that are normal. They don't have memory loss or cognitive dysfunction, but they might have biological signs that are raising concerns for Alzheimer's disease, genetics, for example. But once a patient starts to develop cognitive impairment or detectable changes in memory, we call that mild cognitive impairment. But in order for somebody to stay at the stage of mild cognitive impairment or MCI, these memory changes or these cognitive changes cannot affect their day-to-day function. So they are able to do their normal day-to-day activities independently. However, when the cognitive impairment does start to bleed into their ability to carry out their day-to-day activities, we call that dementia, with obviously the first stage being mild dementia, meaning the higher level things we tend to do, finances, managing money and medications, etc. Those might be impaired, but the basic activities of daily living are okay. But when those basic ADLs start to be impaired, we get into moderate dementia and then eventually severe dementia and then end stage dementia. And I'll come back to this a little bit later, why the MCI and the mild dementia stages are circled. But I think it's important to remind ourselves that dementia is this umbrella term that is basically signifying cognitive impairment that's leading to functional loss. It's sometimes, confused with Alzheimer's disease and where that all falls. But as we can see here in this pie chart, Alzheimer's disease is the most common cause of dementia. According to this, it's around 60% of cases are due to Alzheimer's disease. But as you can see, there are a lot of other causes: vascular dementia, mixed dementia, Lewy body dementia, frontotemporal dementia, and so on. But again, it's important to remind ourselves dementia is this umbrella term, with Alzheimer's disease being the most common cause. So next, let's talk about diagnosis. How is AD diagnosed? Well, in the past, the only way to diagnose a patient with AD was with their symptoms, what we're seeing clinically. Obviously early on, it was based on memory loss. We looked at brains under the microscope in the era of Dr. Alzheimer. But as time went on, we really kind of refined our clinical diagnostic criteria for Alzheimer's disease. And this was really based on, the evolution of neuropsychological testing, bedside cognitive testing. And then eventually we started to use imaging, CT scans or MRI scans. But early on, like I'm saying, 80s, 90s, 2000s, these scans are really just used to rule other things out that could be causing these changes in memory. So really, up until a couple of decades ago, AD was still just this clinical pathologic syndrome, where the only definitive way to diagnose it was with autopsy. However, now in the present, we've had the advent of what we call biomarkers, ways to measure disease while a patient is still alive. And the ones that we tend to focus on are unsurprising: amyloid and tau and neurodegeneration. So a couple of ways we can measure amyloid in a living person: we can look at their spinal fluid, CSF, cerebrospinal fluid, via a lumbar puncture or spinal tap. And these tests might show decreased amyloid in the CSF, which indicates that there are increased levels in the brain. And typically in Alzheimer's disease, it'll also show increased tau in the CSF. Something we're using a lot in the clinic nowadays are amyloid PET scans, which basically tells us if there is amyloid plaque in the brain and how much plaque there is. And then excitingly, there are these blood tests that are being rolled out, which I'll talk about here in the next slide a little bit more. But there's a ratio that we can look at, A beta 42 to 40, and the results of that could tell us if somebody might have Alzheimer's disease. For tau in the CSF, like I said, typically tau levels are increased, which is kind of a general look at neurodegeneration, but specifically for Alzheimer's disease, it's important to look at the number or the value of the tau. And then similarly to amyloid PET scans, there is a tau PET scan. Unfortunately, we're not really using it yet clinically as much. It's very difficult to read. It's difficult to kind of order. There's insurance issues. Eventually, I think this will become much more important, but nonetheless, it's important to mention here that there is a tau PET scan being used mostly in research context right now. Excitingly, there are two FDA-approved blood tests that we can now use for diagnosing Alzheimer's disease. The first one is p-tau 181. So this is typically used in primary care settings. It's almost like a screening test to screen for Alzheimer's disease in patients that have cognitive changes. And then there's a p-tau 217 test that we use more in specialty clinics like Barlow, for example. And this kind of helps us determine who may need more of a workup with an amyloid PET scan, for example. And then we can look at neurodegeneration in the living human by just their MRI. Now we have kind of more refined volumetric structural analyses. We can look at the size and the structure of specific parts of the brain that might lead us to believe Alzheimer's disease is the culprit of their memory loss. And then we also have FDG PET scans, which some of you may be familiar with. We inject a patient with radioactive glucose, and it goes up to the brain, and we can measure how well the brain is metabolizing this glucose. It tells us if there's neurodegeneration or problems going on in the brain. And then this left side, as I'm sure you've been following, just kind of a healthy brain versus Alzheimer's disease brain, looking at atrophy, FDG, glucose metabolism, amyloid PET scan, and tau PET scan. You can see really the differences between a healthy brain and an AD brain. And like I mentioned, these plasma biomarkers or these blood tests are very exciting and kind of up and coming. And don't think you have to memorize this whole table. I just put it up there to show you that there are a lot of tests that are being rolled out in the plasma. But the one in the middle, that row in the middle with p-tau 181 and p-tau 217, you might hear more about, because those are going to be used more and more in the clinic to screen for AD and kind of determine who might need more of a workup to investigate for Alzheimer's disease. And then I just like to show this picture too. Again, there's a lot going on. Don't feel like it needs to be memorized by any means, but it just kind of shows you the timeline of biomarker development over time, from back in the 90s with CSF, and that's really all we had, to imaging, to now blood-based biomarkers, and going further in the future with more blood-based biomarkers. So I like this picture. Let's talk about treatment. So how is Alzheimer's disease treated? Well, in the past, there wasn't much. As the disease progresses, we know that neuropsychiatric symptoms can come out, behavioral dysregulation. So really, it was just kind of symptomatic treatment using antipsychotics, sometimes sedatives, but eventually patients kind of across the board oftentimes need to be institutionalized. But after this came a new hypothesis of what might be going on with this disease. We call it the cholinergic hypothesis, and it's based on a neurotransmitter in the brain, a chemical in the brain that helps cells communicate with each other, called acetylcholine. And there's been a lot of research that shows in AD, acetylcholine is deficient. So the thought is, if we can give a medication that increases the levels of acetylcholine, it could help with memory and thinking. So, like I said, in Alzheimer's disease brains, there's a specific part, it's called the nucleus basalis of Maynard, degenerates, and that's where a lot of these cholinergic neurons are housed. So we lose those. In order to replace the acetylcholine, there's a class of medications that we use called anticholinesterase inhibitors. Basically, it's blocking the enzyme that breaks down acetylcholine so as to keep the levels high in the brain, or normal in the brain. And what we see with these medications, which I'll touch on the next slide too, is they oftentimes provide temporary symptomatic relief. Patients might feel their memory is a little bit better, their thinking is a little bit sharper, but they do not slow down the progression of the underlying disease at all. So it's kind of a band-aid. It helps temporarily for a lot of patients, but ultimately doesn't change the course of the disease. And these are kind of three medications that we see a lot in the clinic. Three of the most common anticholinesterase inhibitors. On the far left, there is donepezil or Aricept. It's a pill, and it's usually the first line pill we use. Galantamine is another pill, works very similarly. They're in the middle. But with these medications, there are side effects, as every medication has, with kind of the main one being GI upset. Your stomach can become upset. So if a patient has trouble tolerating a pill, there is a transdermal patch system, rivastigmine or Nexelon patch that we can use that works very similarly, and patients tend to really tolerate it better than the pill. Another hypothesis related to neurotransmitters and chemicals in the brain is the glutamate hypothesis. So glutamate is kind of the main excitatory neurotransmitter in the brain. It helps things kind of go. However, research has shown that in Alzheimer's disease, glutamate can kind of be working overtime and cause a lot of what we call excitotoxicity, glutamate toxicity. So we thought, not me, but people smarter than me in the past thought, hey, if we can kind of calm down glutamate with a medication, maybe that will help. And that led to the development of a medication called memantine or Namenda. And this works by blocking NMDA receptors, which can downstream help reduce glutamate levels. Similarly to the anticholinesterase inhibitors, these help symptomatically, temporarily, but they ultimately don't slow down the progression of the disease. And for memantine, research has shown that it's really more effective for patients that enter kind of that moderate dementia stage. We typically reserve it for moderate dementia. Sometimes, we'll use it earlier on, but technically that's kind of what research has shown it to be when it's most effective. Other than medications, something we harp on for every patient is lifestyle, because decades of research has shown that improving lifestyle can actually slow the progression of Alzheimer's disease, and really all dementia for that matter. There's a lot of hypotheses as to how this works. Oxidative stress, making mitochondria work better, improved insulin signaling, reducing inflammation. But ultimately, we do know that focusing on these specific lifestyle interventions can really, really help slow down the progression of the disease. If you think about diet, influencing the Mediterranean diet or the MIND diet, a lot of leafy green vegetables, berries, nuts, fish, etc., while kind of limiting butter and cheese and red meat. So we always talk about that with our patients. Arguably even more important is exercise, specifically aerobic exercise. So getting out 20 minutes per day, getting your heart pumping a little bit has really been shown to improve blood flow to the brain, to the memory centers. It can improve mood and sleep. And for sleep specifically, we aim for that 8-hour mark, 7 to 9 hours at least. Well rested in the morning, really, really good sleep has been shown to improve memory and thinking, that's for sure. And then beyond that, we think of cognitive stimulation or cognitive exercises for your brain, puzzles, crosswords, etc. And it's even better if you do these things with other people, because isolation has also been shown to be a really poor prognostic factor for dementia. So if you get out in the community and socialize with other people, maybe do puzzles or crosswords with other people, it can be really, really helpful in slowing the disease. And then finally, focusing on your physical and medical health, specifically what we call vascular risk factors, your blood pressure, cholesterol, blood sugar, really getting those under control with a doctor is huge. And then obviously if you smoke, stopping smoking is very important as well. So let's talk next about this amyloid hypothesis and how we're treating it. So I'll come back to this schematic. Like I said earlier, we know that amyloid builds up years before symptoms actually happen, before we can see something clinically. So the thought is, if we can clear amyloid, maybe symptoms get better. What I'll say here is it's been a long time coming before we got medications that were approved and were effective. And there's a couple thoughts as to why it has taken so long. One, a lot of trials probably recruited patients that didn't have Alzheimer's disease because we didn't have all of these biomarker studies that help us diagnose the disease in living people. Also, a lot of the initial trials focused on patients that had already developed symptoms and were already kind of in that moderate, severe stage of dementia. So it's probably, unfortunately, too late to remove the amyloid from those patients because we know it's been there for years and years and years. So these recent trials, there in the yellow where it says need to focus here instead have recruited patients, one, based on their biomarkers, so amyloid PET scan, for example, or CSF, but it's focused more on the early kind of stages of the disease, preclinical, mild cognitive impairment, and mild dementia. So excitingly, then came our kind of technically second, but first FDA approved anti-amyloid therapy called Lecanemab or Leqembi. So it was approved in 2023, and the way it works is it's an antibody that targets what we call protofibrils of amyloid. So it's before the plaque actually forms. It's given via an IV, goes in and it removes the plaques basically from the brain. The timing is it's every 2 weeks for 18 months for a total of 39 infusions. And what the clinical trials showed is that it did statistically significantly slow the decline of the disease by about 27%. It also showed that it's very effective at removing the actual plaque from the brain. So if you looked at a scan before and after treatment, the medication was very effective at removing that plaque. And right now, there's really no standardized approach for what patients get started on the medications and which don't. So here at NYU, we have a review committee that I'll talk about here in a little bit to determine who's most appropriate for these medications. And here's a couple pictures just from the actual trial. It's called the Clarity AD trial for Leqembi, where on the left, you can see that when they looked at something called the clinical dementia rating sum of boxes, basically a way to measure clinical progress, firsthand. You can see the lecanemab line kind of shallows out compared to the placebo line over 18 months, meaning the cognitive decline was less at 18 months for Leqembi compared to placebo. And again, that's kind of how they got that 27% mark of statistical significance. Then on the right, like I said earlier, lecanemab or Leqembi was very effective at removing the actual amyloid on PET imaging. You can see with placebo, it actually kind of increases over time at 18 months, whereas with Leqembi, it really, really declines over time. So next, another anti-amyloid therapy that we have that was approved about a year after Leqembi is donanemab or Kisunla. So it works very similarly. It's an IgG1 monoclonal antibody that targets a little bit more downstream in the development of the amyloid plaque. It actually targets kind of the plaque itself. But similarly, it's given via an IV. Different than Leqembi, though, it's a monthly infusion for 12 months. So the trials kind of stopped it at 12 months, and if amyloid was cleared, you could stop the medication altogether. It was statistically significantly able to slow progression of clinical disease by about 35%, so a little bit stronger than Leqembi. It was also extremely effective at reducing amyloid from the brain. And I'll pull up kind of similar pictures from the trial where you, again, as you can see, that CDR sum of boxes, the line shallows out for Kisunla compared to placebo. And on the right for the amyloid PET level of amyloid plaque in the brain, the donanemab or Kisunla line is much lower than that of the placebo at the end of the treatment. So a lot of questions we're getting now, because we are treating many patients with these medications, is what happens when it's over? What happens when my Leqembi protocol at 18 months is done? Well, the first thing we do is we repeat an amyloid PET scan to see how much amyloid is left, if any. So that kind of is the first step that drives our decision. But ultimately, if all of the amyloid is cleared, meaning there's a centiloid value, I won't get too much in the weeds, but centiloid value is kind of the number that we use to quantify how much amyloid plaque is in the brain. If that's below the number 30, we call it negative. We say there's not significant evidence that there's plaque that's clinically meaningful in the brain. So with Leqembi, after 18 months, a couple options that the patient has is one, can stop treatment altogether. Maybe it was really cumbersome to get to the infusion center. Maybe you didn't notice a lot of benefits, so that's totally an option at the end of the treatment. If that centiloid value is above 30, meaning there's still, clinically meaningful plaque in the brain, typically we say, let's repeat the course, maybe 6 months, 12 months, every 2 weeks. But if that centiloid value is less than 30, The patient can opt to space those the infusions out to every 4 weeks, similar to Kisunla. Or a newer option that we're just starting to roll out now is it's called Leqembi iClick. It's an at-home auto injector, subcutaneous, once weekly shot, kind of like an Ozempic pen that you do at home once a week, that has been approved for maintenance therapy after Leqembi is initially done. For Kisunla, it's very similar. If amyloid is cleared from the brain, patient totally has every reason to just stop treatment altogether. I mean, that's kind of what the trials suggested anyway. But what we're seeing is a lot of patients actually prefer to kind of continue on with treatment, even if there is still amyloid. And at that point, we would switch to Leqembi, typically, via every 4-week infusion, or patients have the option to do the iClick as well. And it's just a picture of the iClick there on the right. But we cannot talk about these treatments, anti-amyloid therapy, without talking about their side effects, right? And the big one that we are seeing, both in the research setting and in the clinic, are something called ARIA, amyloid-related imaging abnormalities. There are two types of ARIA: ARIA-E, E standing for edema or swelling, and ARIA-H standing for hemorrhage or bleeding. And there's kind of a schematic showing on the left ARIA-E. These are MRI scans, and you can see, I don't know if you can see my pen, but there's kind of this brightness here in the brain, white kind of areas. That's swelling. That's edema. And then here on the right, you can see these tiny black dots we call microhemorrhages, little areas of bleeding. So we're seeing both types of ARIA from these medications. So the question becomes, how do we monitor for this? And it's a really important question, because if this last bullet point is kind of most pertinent, most ARIA is asymptomatic. Patients don't feel anything, greater than 75%. Some patients do, headache, confusion, etc., but most of the time it's asymptomatic. So in order to monitor for ARIA, we perform frequent MRI scans. For Leqembi, it's prior to the 3rd, 5th, 7th, and 14th infusions. And for Kisunla, prior to the 2nd, 3rd, 4th, and 7th infusions. You'll notice that for both drugs, most of the MRIs are performed early on in the course. That's because what we see is ARIA really occurring, not exclusively, but almost exclusively early on in the treatment course. And then I won't get too much into the genetics and the risk factors, but it's important to mention that a way we can kind of risk stratify for which patients may develop ARIA is to check their genetics, specifically their ApoE genotype. And if a patient has what we call the ApoE4 allele, either one or certainly 2 copies, that does place them at higher risk of developing ARIA. So that goes into the discussion of picking the medication, and really even if the medication is right for you. This is just a little overview of the two drugs side by side, their targets, their duration. You can see their percent of decline. Donanemab being a little bit more effective with slowing decline. However, you can see that the ARIA rates for donanemab or Kisunla are higher. So it's more effective, but ARIA rates are a little bit higher, unfortunately. So there's a bit of a trade-off. So that brings me to this. What are we seeing in the real world? What are we seeing here at NYU in terms of our outcomes for these drugs? I kind of alluded to it earlier, but we have a committee here at Barlow Lecanemab and Donanemab Review Committee. So it's made up of all of the cognitive neurologists here, as well as the fellow and all of the providers. We meet weekly and we go over patients that have either been seen here in the clinic that we think could be good candidates. Sometimes they're seen by general neurologists over on 41st Street, for example, or geriatricians. But nonetheless, they're referred to us, and we take the time every Tuesday to go through a list of patients. We review their charts, their clinical history, their imaging, their genetics, etc., and make a determination if we think they could be appropriate for these anti-amyloid therapies. And ultimately, in order for them to be approved, everyone has to vote unanimously that they would be a good fit. Just some stats. This is, I think, as of a couple of weeks ago, but I'll just draw your attention here. We have about 280 patients that are currently receiving infusions, with a few more kind of coming down the pipeline. So this is something that is very common. We are really seeing a lot of interest, and we are prescribing these medications here at Barlow. frequently. And they're, like I said, patients are interested in these treatments. And here there's about 73 patients that have completed the initial um, therapy plan. And I'll just kind of go to the next slide to go through some of the stats. I know it's a lot of words, but the big takeaways here are for the patients that have completed, this is for Leqembi specifically, you'll see that the clinical dementia rating scale here is about 0.67, which really just means that we had a mix of patients at the mild cognitive impairment stage and the mild dementia stage. At 18 months, the average CDR did increase, meaning clinically they worsened a little bit, just on average. But this change is very kind of similar to what we saw in the trial. So it's not really surprising. We know that this disease progresses with or without treatment. But this kind of progression rate is slower than what I guess we would see without treatment. That's according to the trials. And then another thing that we like to do in the clinic, some of you may have experienced this test. It's called the Mini Mental State Examination, or the MMSE. It's a 30-point test, and we kind of like to trend the patient's scores over time just to get a sense of maybe how their memory and thinking is doing that day. And the average kind of pre-treatment score was 24 out of 30. And then by the end of the 18 months at their follow-up, the average score was about 21. So again, a little bit of a decline, but it's a decline that we saw very similar to the trials, and something that we would expect over time anyway. Another really important clinical measure for these patients that have completed treatment is how much amyloid is actually cleared from the brain. So I mentioned that centiloid value earlier, the number that we use to determine how much amyloid plaque is in the brain. Anything above 30 is considered positive. So the average pre-treatment centiloid value was about 85, and the average post-treatment value was 21. So on average, patients' scans were negative. There's an average percent centiloid reduction of 77%, very significant, with 37 of these patients having a negative scan, for about a 61% clip on negative scans. So unsurprisingly, we know these drugs are very effective at removing the amyloid. We need more time, really, I think, as a takeaway, to determine the clinical progression and slowing of progression here in the real world. But just preliminarily, we're seeing very similar results to what the clinical trial showed. In terms of adverse effects, so this first row, IRR, this is infusion reactions. I didn't touch on this much earlier, but it's basically, anytime you receive an infusion treatment, you're at risk of having things like, pain, swelling at the infusion site, maybe flushing, chills, etc. So we have about a 9% rate on infusion reactions for our patients. But in terms of ARIA, really, and again, this is not fully updated data, but for ARIA-E, we've only had about 3 patients experience ARIA-E for about a 1%. ARIA-H is a little bit more prominent. Almost 10% of patients have experienced ARIA-H. And then a combo of E and H, 7 patients had experienced a combo. And like we saw in the clinical trials, unsurprisingly, the majority of these patients who experience ARIA are carriers of that ApoE4 genotype, either having 1 copy or certainly 2 copies. So we're almost done. Brings me to the kind of the last segment here. Where do we go in the future? So we talked about the past. We talked about the present, anti-amyloid therapy, and what we're seeing here in the clinic. But where do we go in the future? And I really like this picture because it's so crazy to me. I mean, it's basically showing all of the clinical trials that are going on to treat this disease that we feel so passionately about treating. And this is updated every year. So this is as of 2025. There are well over 180 randomized clinical trials underway. But interestingly, only about a third of them are targeting amyloid and tau. So there is like 2/3 of these trials that are looking at different methodologies, different mechanisms to target to treat this disease, whether it's biologic treatment similar to lecanemab or donanemab, or cognitive enhancers like donepezil or galantamine, for example. There is a bunch of trials going on to treat the neuropsychiatric symptoms of Alzheimer's disease. And then there's small molecules that target the disease that are becoming very, very exciting as well. So all this to say, again, don't need to memorize all of this. It's just kind of telling us that there's so much research going on and a lot of different mechanisms. But I'll just highlight 2 specific mechanisms that I think are kind of close to getting there and are exciting, starting with anti-tau treatments, and I think it's especially exciting because, like I talked about earlier, amyloid starts the domino effect is kind of the hypothesis. Amyloid builds up, and then amyloid leads to tau starting to aggregate and forming these tangles, and tau ultimately drives neurodegeneration and symptomatology. So the thought is, if we can remove tau or target tau, it could, hopefully slow the disease, improve patient outcomes. There's a couple of approaches. Anti-tau monoclonal antibodies are being tested, similar to Leqembi and Kisunla. There are tau vaccines that have been tested, microtubule stabilizers, and then compounds that prevent the aggregation of the actual plaque or the actual tau tangle formation. So a lot of different ways we can target this one protein, but unfortunately, as of right now, none of these have demonstrated clear phase 3 success. But unsurprisingly, there are still a lot of trials ongoing, and I think it's a reason to be excited, in my opinion. And then just one more mechanism that I think is exciting as well is targeting neuroinflammation. And I mentioned it earlier. The immune system, we think, plays a really pivotal role in disease progression. But when we think of the immune system, I think we typically think of it as a positive thing. It helps us fight off viruses, bacteria, etc. So early stage, even in Alzheimer's, it could be helpful. It can help clear amyloid and tau, maybe. It can certainly support the brain's overall health by removing other harmful proteins. However, later in the stage, we think it's probably harmful because it drives inflammation, and chronic inflammation can worsen amyloid and tau driven pathology. It can just damage the brain overall. And it, with inflammation comes more neurodegeneration and brain cell loss. So how do we tackle neuroinflammation? There's a couple different thoughts. One, you could boost the protective immune response early via something like a vaccine, or you could block inflammation later, targeting the brain cells that drive inflammation, the microglia. So there's a couple thoughts, but overall, the goal is just to harness our own innate immune system in order to protect the brain without causing more problems, without triggering more damage. So something to keep an eye on is neuroinflammation as well going forward. So just some conclusions, some take-home points from the talk today. Alzheimer's disease has changed a lot from its origins. From back when Dr. Alzheimer first worked with Augusta Dieter to now, there's been a ton of changes. And what we've determined is really early detection of the disease is going to be huge in order to really target those early brain changes. All research is pointing that early detection is huge. And with the biomarker formulation and ongoing research, that's only going to become easier. Anti-amyloid therapies are promising. Here in the clinic, we are seeing promising results, and patients tend to really tolerate them well. They tend to feel that they're seeing some sort of benefit, or they feel at least hopeful about these treatments. So we feel the same way, and I would say that they're promising going forward. And then overall, the future is bright. I choose to believe that, and I showed the picture of all of the research that's going on to fight this disease. But ultimately, we need more trials and more research and more interest, in looking at how we can cure Alzheimer's disease. So I want to just thank a few people. Dr. Rajiha Ahmed, she gave a very similar talk. I based a lot of my talk on her talk. So thank you so much. Her presentation was incredible. Dr. Arjun Masurkar, my cognitive fellowship director and mentor, thank you so much to him for all of the help with not only this talk, but everything in the past year. The entire ADRC team here at NYU, the entire Barlow Center team here, my past co-residents and faculty mentors, and then finally, all of our patients and your families. Thank you so much for working with us and being involved and being interested. It's very, very important, and I can't thank you all enough.